Great, fantastic. So welcome everyone, and thank you for joining us this evening across different time zones. So it's really great to have it organized and great to see so many people in attendance. So this is a new collaboration that we're trying out this evening. And you'll see there's a few different acronyms on the poster and advertisements, but best to explain what some of those mean. So this today is hosted by GASOC, the Global Anaesthetic Surgical and Obstetric Collaboration, so working towards safer surgery and anesthesia globally. Today we have the privilege and pleasure of working with some trainees from Zambia and Ethiopia in association with the Zambia and Ethiopian Anaesthetic Societies. And this is in collaboration with the Global Anaesthesia Development Partnerships, which takes in two partner organizations, Ethiopian Anaesthesia Development Program and the Zambian Anaesthesia Development Program. So today we're trying to bring all those different strands together, hopefully enjoy a really cool collaborative journal club. So with that being said, we have two presenters today, anesthesia trainees from Zambia and Ethiopia, to deliver two different papers. And we'll hear from both of them. And then once we've heard those talks, we'll then have an opportunity for discussion and questions, which will hopefully generate a great deal of interest amongst us all. So without further ado, I'll just introduce our first speaker. And then once we've completed that talk, we'll have our second speaker introduced and go from there. So I'd just like to introduce Dr. Sarah Musalale, who's a second-year anesthesiology resident from the University Teaching Hospital of Lusaka in Zambia. And she's very happy to say joined us today to deliver a talk on a paper, Preoperative Fasting Times in Elective Surgical Patients at a Referral Hospital in Botswana. So that's really good. So please do take it away. And we look forward to hearing what you have to say on
that. Good evening, everyone. Let me just share my screen. So I chose this topic because I thought it was similar to our setting in Zambia. As already mentioned, I'm Dr. Sarah Musalale, and I'll be presenting on a paper that was done in Botswana, Preoperative Fasting Times in Elective Surgical Patients at a Referral Hospital in Botswana. And it was published at Pan-African Medical Journal on 16th March 2016. So that will be the format. We'll go through the background, study design, results, summary, and impact. So fasting before a procedure is important to avoid regurgitation and aspiration. However, prolonged fasting is unnecessary and may cause complications such as distress, especially in children, headache, hypoglycemia, ketoacidosis, dehydration, electrolyte imbalance, and it can even cause hypotension during anesthesia. There was also a study which was done where they studied children between 6 months and 6 years, and they showed that after 10 to 16 hours of fasting, they were disposed to having hypotension in anesthesia. And then it can also cause post-operative nausea and vomiting, increased insulin resistance, delayed recovery. And then for mothers who are starved for a long time, for Caesar, it can cause hypoglycemia and acidosis in neonates. So according to the American Society of Anesthesia, the fasting recommendations are 2 hours for clear liquids, 4 hours for breast milk, 6 hours for solid infant formula, non-human milk, and light milk. And then for fried and fatty foods, this can cause prolonged gastric emptying and require 8 hours of fasting. So the possible causes of prolonged fasting, it could be lack of knowledge regarding the rationale for preoperative fasting, rapidly changing surgical schedules. So they would prefer to have people fasted from a certain period of time in case they are not set, so they would change. Absence of a formal fasting policy or staff members' inadequate knowledge of the policy. General mistrust on the part of the practitioner that patients will understand and comply with the fasting policy. And then starving for midnight, regardless of the time the procedure will be done. So it was a cross-sectional study of preoperative fasting times. It was for elective surgical patients at Prince Marina Hospital in Botswana and took place from June 5th to September 3rd, 2015, and published, as said earlier. So the population, they took a sample size of 260 patients aged 5 years and above with ASA 1 and 2. The sample size was calculated using the Cochrane's formula for minimum sample size determination in a cross-sectional studies. The exclusion criteria included children less than 5 years, emergency surgery, patients with ASA 3 and above, pregnant women, patients at increased risk of aspiration such as obese, patients with symptomatic gastroesophageal reflux disease, those with hypertension, achalasia, diabetes mellitus, which causes prolonged gastric emptying, patients on IV fluids, patients with parental enteral tube feeding, and mentally challenged patients. So when the patients came in, they were interviewed at the reception using a questionnaire. And for children less than 10, they interviewed the parents just so that it's objective. So the outcome was patients' social demographic characteristics, fasting instructions were given, the fasting instructions which were given earlier, time of the last meal and drink ingested, and the time that the anesthesia was started was recorded as well. So these were the social demographic data. Most of the patients, more than 70% were 30 years and above, and the mean age was 37.5 plus or minus 18. And then 55.4 were male and 44.6% were female. And then about half of the patient had the secondary education and above. And then most of the patients received GA, which is about 61%, and 38.1% received regional anesthesia. And the majority of them came for general surgery, orthopedic surgery, and dental surgery. So the fasting instructions were delivered by the ward nurses for 148 of the patients, which is 56.9%, and by the doctors for 112 of the patients. And then the majority of the patients were instructed to abstain from both liquids and solids from midnight, while the remaining were delivered other fasting instructions such as not eating or drinking after supper. And then you have to consider that supper for some hospitals is given at 17 hours. So some would even fast on that from that time. Explanation about the importance of preoperative fasting was not delivered to a majority of the patients, which was 94.2%. It was only given to about 15 patients. Then the scheduled time of surgery was not indicated for all the lists. So these are the results which showed that the mean fasting overall morning and after midday was about 15.9 hours plus or minus 2.5, which is the same which is almost the same for liquids and for solids. So the they further divided the hours for before midday and after midday, and it was found that patients had prolonged fasting, especially for those after midday. So for before midday, it was about 14.3 plus or minus 1.8 for liquids, and after midday, it was 17.1 plus or minus 2, which is similar also for solids. And then the p-value was less than 0.001, which is statistically significant. So the conclusion was that the mean fasting time was 7.65 times for clear liquids and 2.5 times for solids, longer than the recommended ASA guidelines. And then there was no preoperative fasting policy in the hospital, and a single fasting instruction, which stopped them from taking foods from midnight, was usually given. So the for the strengths, strengths of the study, it was focused. And then, so to be objective, the questionnaire was also administered to parents or guardians for children 14 years and below. And then the weakness is that it was done in a short period of time. However, it shows us that it gives us a picture of what usually happens in the hospital. So the implications and potential for impact. So we need the theater list should be included. The theater list should include the scheduled time, so that when you're telling the patients to fast, it will be easier, especially for those who will be done in the afternoon. You can tell them to take a light meal in the morning. The time of proposed surgery should be checked before administration of fasting instructions. Nurses and doctors should discourage the traditional new peorum after midnight and work together to ensure that instructions are consistent with the ASA guidelines. And then I think it would also be interesting to carry out the same studies in our setting in Zambia. I think the questions will come later on. That is all I had.
There you go. Fantastic. Thank you very much, Musalale, for giving us that presentation. And yes, we'll please keep posting any questions you have in the chat box. Post to everyone. We'll collate those, and we'll address those all at the end, and hopefully generate some discussion that can maybe compare practices between our different locations. So thank you. So we'll come back to you later with the questions. So Rufi, if you don't mind, I'll just hand over to you, my fellow anaesthetic for GASOC, and we'll introduce the second paper.
Thank you, Sarah, for your presentation, and we're moving on to our next speaker and presenter. It's going to be Dr. Fekadu Getahun, a second-year anesthesiology resident of the Tikur Anbesa Specialized Hospital, in short TASH, at Addis Ababa University in Ethiopia. And he is going to be presenting today to us about balanced crystalloids versus saline in critically ill adults. And he's also part of EADP, as well as mentioned by Ryan. So welcome, Fekadu, and thank you for taking part in this event today. Fekadu may have had a connection problem. Fekadu, can you hear us?
Yes. Sorry for this.
No worries. You're free to go.
Am I audible now?
We can just about hear you, but if you have any presentation to share as well, if you could click on the screen share now, that would be great.
Is that visible now?
Yes, that's brilliant. Thank you.
Okay, thank you again, GASOC family as well as team from Zambia and participants from Ethiopia. I'm Fekadu. This is my journal club presentation. There is an article from New England Journal of Medicine. Written on balanced crystalloids versus saline in critical ill patients. It is called the SMART trial. This is the pico of my research. The population is 15,800 to 175 intensive care units at academic center in Vanderbilt University Hospital. The intervention was intravenous administration and comparison of balanced crystalloids versus saline, and the outcome was composite of outcome of use from any cause, the new renal replacement therapy or persistent renal dysfunction. This is my outlines from the research. We will have introduction part, objectives, methods, results, conclusion, and limitations and strengths of the study. And the critical appraisal as well as references for my critical appraisal and the source. Regarding to the introduction, balanced crystalloids are commonly administered in critical care, yet the question of whether crystalloid composition affects patient outcome remains unanswered, and historically 0.9% of sodium chloride, which is commonly called as saline, has been the most commonly administered intravenous fluid, and data suggests that intravenous saline may be associated with hyperchloremic metabolic acidosis, acute kidney injury and disease, and crystalloid solutions with electrolyte composition closer to the plasma.
Fekadu, I'm very sorry to interrupt you, but I'm just hearing a lot of interference from your microphone. Do you have, are you using a headset or something at the moment? Can you try without the headset? Because we can't hear you very well with the headset on at the moment.
Okay. Is that audible now?
There's still some interference, but if you could just recap the last few points really quickly, that would be brilliant. Sorry about that.
I didn't use headset and there is no interference except the connection may be poor. So, is that audible now?
There's still some interference from somewhere, but keep going for now without the headsets, I think. And just try to speak up a tiny bit more. Thank you.
Okay. As an introduction, intravenous crystalloids solutions are commonly administered in critical care. Yet the question of whether crystalloid composition affects patient outcome remains unanswered. So, commonly 0.9% of sodium chloride, which is called saline, is used as an intravenous fluid. And some data suggests that intravenous saline may be associated with hyperchloremic metabolic acidosis, with kidney injury and days, and crystalloid solutions with electrolyte composition of closer to that of plasma, such as lactate reserves and plasma lights, represent an increasingly used alternative to saline. So, from several observational studies and before and after trial, they suggest that balanced crystalloids is associated with lower rates of acute kidney injury, renal replacement therapy, and this. However, two pilot trials before this research showed no significant difference in any patient outcome. For this, SMART trial was conducted as SMART Med in medical patients and SMART Search in non-medical patients in the intensive care units. And its hypothesis was that use of balanced crystalloids would result in a lower overall incidence of death, new renal replacement therapy, and persistent renal dysfunction than saline. So, to do this research, the ethical considerations were approved by an institutional review board at Vanderbilt University. with a waiver of informed consent. It was registered online before registration and was overseen by an independent data and safety monitoring board. And all outcomes to vote for the accuracy and completeness of data and for the fidelity of the trial to the protocol. For this, consideration was taken. The objective of the study was to know whether balanced crystalloid or saline results in better clinical outcome when used for intravenous fluid administration in critically ill adults. So the method includes the trial design. It was pragmatic, unblinded, cluster, randomized, and multiple crossover trial. 5 ICUs at Vanderbilt University Medical Center from June 1, 2015 to April 30, 2017. The method included all adults 18 years or older who were admitted to the participating ICU during the trial period, and patients who were discharged and readmitted were also enrolled again and participate in the trial. And patients with age less than 18 and admitted to the non-ICU ward from the emergency department were excluded. So the randomization was for each member of trial, participating ICUs were assigned to the use either balanced crystalloids or saline for any intravenous administration of isotonic crystalloid. And the ICUs were randomly assigned to use saline during even number months and balanced crystalloids during odd number months, or vice versa, as you see from the diagram below, for about different months in 5 different ICU setups. And the randomization to allow coordination of crystalloid use between ICUs and the emergency department and operating rooms. 3 ICUs that admit majority of patients from the emergency were underwent randomization together, and 2 ICUs that admit majority of patients from the operating rooms were also randomized together. This was the randomization diagram, which is congested and has multiple randomization processes with multiple subgroups, as you see from the diagram. A total of 15,802 patients were included in the primary analysis, 7,860 in the saline group, and 7,942 in the balanced crystalloid group. And from initially enrolled patients, from each group, there were patients excluded because of the age less than 18 years. Otherwise, all enrolled will participate to the end of the trial. So, regarding the blinding, patients, clinicians, and investigators were aware of group assignments, except some investigators who investigating the indications for new renal replacement therapy were blinded. Otherwise, patients, clinicians, and investigators were unblinded. The treatments were in the saline group, 0.9% sodium chloride was given, and in the balanced crystalloid group, Ringer's lactate and plasmalide were used, and the treatment inclusion determined with sedative hyperkalemia or brain injury, at which saline rather than balanced crystalloids were used in the process. The data collection was from routine care and electronically extracted from electronic health records was used, and pre-enrollment renal function, demographic characteristics, diagnosis, predicted response in hospital-based orders for intravenous fluids and blood products, plasma electrolyte and creatinine levels, and reset of renal replacement therapy before enrollment, and vital status at hospital discharge was enrolled prior to the study period, and trial personnel who were unaware of the group assignment performed the manual chart reviews for the initiation of renal replacement therapy. And regarding the outcomes, the outcome was primary outcomes included proportion of patients who met one or more criteria for a major adverse event within 30 days, which is next 30. The composite of this new receptor of renal replacement therapy or persistent renal dysfunction. One or more of them were considered as primary outcome, and secondary outcome was including in hospital days before ICU discharge or at 30 days or 60 days, ICU 3 days, ventilator 3 days, dialysis pressure 3 days, and days alive and free of renal replacement therapy during the 28 days after enrollment were considered as secondary clinical outcomes. Regarding the statistical analysis, it was conducted as a level of each patient's hospitalization in an intention to treat fashion, and continuous variables were reported as means and standard deviations or as medians and interquartile range. Categorical variables were reported as frequency and proportions. And two-sided p-value of less than 0.048 indicates statistical significance for the primary outcome after accounting for interim analysis. And using reporting secondary outcomes, the likelihood of observing p-value of less than 0.05 for at least one secondary outcome by chance alone was around 51.2%. And all analyses were performed with statistical software R version 3.3.0 with specified analysis code. And these were results of participants at baseline, and almost all baseline characteristics between the two groups were almost comparable. And this one is the volume of intravenous azotempic crystalloid administered according to the group. As the day since ICU admission increases, the cumulative fluid is as shown. The left one balanced crystalloids and the saline group on the right side. So
Sorry, everyone. It seems like Fekadu's connection problem happened again. So we'll just wait for him for a couple of minutes to rejoin the Zoom call. Sorry, everyone.
Okay, no worries. While we're waiting, we can maybe we can ask him to join with a different device as well to try and improve the audio. I know it's a bit difficult, but while we're waiting, we can discuss and ask any questions we had about our first presentation or anything we've had so far. So please feel free to post anything in the message group, or indeed, if you'd like to, you can raise your hand and speak live if you prefer as well. And we'll take any questions that you have. Oh, Fekadu's back. Maybe we'll be able to finish. Fekadu, how are you getting on?
sorry, can I finish? Sorry for the interruption.
Yeah, it'd be great to finish if you can.
Yes.
Also, Fekadu, your connection, I think due to your connection, the audio continued to be quite crackly. So if you're able to speak up as much as you can so that we hear you over the crackles, that would be brilliant. and then maybe we can try like a phone or something for the discussion later on. But please continue with your presentation. Thank you.
So here it is the chloride concentration versus bicarbonate concentration, as it is seen from the chart and the graph. Fewer patients in the balanced crystalloid group than in the saline group are measured plasma chloride concentration greater than 110 millimole per liter, which is 24.5% versus 35.6%. Plasma bicarbonate concentration was less than 20 millimole in the balanced crystalloid group than in the saline group. A total of 1,139 patients, 14.3% in the balanced crystalloid group and 15.4% in the saline group had a major adverse kidney event with a p-value of 0.04%. It is seen in the table as well, the primary outcome, which is major adverse kidney event within 30 days, is 14.3%, shaded in yellow, in the balanced crystalloid group and 15.4% in the saline group. This table also shows subgroup analysis of rate of composite outcome of this and new renal replacement therapy or persistent renal dysfunction. It is shown that most of the outcomes and the ICU subgroups had better outcome in the balanced crystalloid group towards the left direction than towards the saline group, except that patients with TBI were better managed with saline. So the conclusion was among critically ill adults, the use of balanced crystalloids for intravenous fluid administration resulted in a lower rate of composite outcome of this from any cause, new renal replacement therapy or persistent renal dysfunction than the use of saline. So the limitations of this study were it is unblinded. The participants, the investigators, and the clinicians were not blinded. It is done at a single academic center, which is Vanderbilt University Hospital, and difficult to generalize to other centers from different countries. And the treatment bias can happen because clinicians decide to initiate renal replacement therapy, and it may be susceptible to bias. And censoring data at hospital discharge may underestimate the true incidence of this at 30 days. Because data was censored the hospital at hospital discharge or at 30 days from hospital discharge, whichever comes first. So patients discharged earlier than 30 days may have may die, and it may underestimate the true incidence of this, or it may overestimate the true incidence of persistent renal dysfunction, because patients with renal dysfunction may have improved after 30 days. And it does not inform the choice between lactate ringers solution and plasma light. It used the two interchangeably in this study. And the strange was it was done at different units in the university hospital, the medical, cervical, neuro, cardiac, and trauma ICU, and it was an intention to treat. Patients can be treated in the middle of the trial with indications. And the large sample size has statistical power to detect small differences in patient outcome and minimize selection bias and improve generalizability, because all patients are adult patients participating in the ICU were enrolled and minimize selection bias. So the critical appraisal addresses the following questions. It addresses clearly focused question, yes. and the assignments to intervention were randomized, and all participants who entered the trial properly accounted for its conclusion, except that those excluded due to age, all were randomized and accounted for the conclusion, and the participants and investigators were not blinded. And the group was similar at the start of the trial. Baseline characteristics were similar in both groups, the saline and balanced crystalloid group. And they were treated requiring the experimental intervention, and the effects of intervention were reported comprehensively, and the estimate of intervention and treatment effect was reported with precision, and the benefits of experimental intervention were outweighs the harm, and the question can be the results can be applied to our population context. Actually, the results, the comparison fluids are already being used in the treatment, so it can be used in our context. So the reference were those appraisal checklist on Google, and the New England Journal Medicine based on this link. Okay, thank you. This is my presentation.
Thank you very much, Fekadu, for your presentation on crystalloids, balanced crystalloids versus saline. So if Sarah could join in as well, we'll start the discussions.
Great. So Sarah, are you there? Fantastic. So yeah, so as I said, please post any questions you have in the side chat, or just use the raise your hand function, and you can ask live or discuss anything you wish. So we'll just wait for anything to come in. Just to kick things off, considering that our speakers today have chosen these topics and chosen these papers and wanted to speak about them, I just wonder if they could tell us a little bit more for Sarah about, do you have any fasting protocols in your workplace? And this paper you've chosen, will it influence you to introduce anything in your setting or change anything? And the same for Fekadu, this paper, have you chosen it because you see a problem, or will this influence how you work in your setting as well? Or is this different to how you see things? Maybe Sarah, if you'd like to start.
Okay, thank you. Actually, I was very interested in this article because that's what I see in my hospital. There's no fasting protocol, and most of the time, as the paper showed, patients are told to fast from midnight or from the Last Supper. So you find patients are dehydrated and they are fasted for a really long time. Which I've even seen with Caesars, with the pregnant women. Sometimes they come in with 12 hours of fasting, sometimes even 24 hours it happens, because they would tell them from the referral clinics that your case is an emergency, so don't eat anything. So and then when they come in, there's a long list. So you find the patients are really fasted for a long time, both for electives and emergencies. So this this article motivates me to speak with the administration and maybe try to come up with a fasting protocol. And personally, I think I would also want to do a study in my area, focusing on pregnant women.
That's great. I think it's really interesting, yeah, to focus on one area as well. In particular, I think in the paper mentioned a particular difficulty with pediatric patients as well, which I'm sure is difficult when it comes to fasting. So that's an area to consider further. Fekadu, and same sentiment. Does this paper inspire you to make any changes or offer any suggestions of change within your practice in your area, particularly our patients? Do you think this paper offered enough to make you think that you needed to make any changes?
Okay, thank you. In our clinical practice and in our area, we usually to give our patients one of the two fluids, either balanced crystalloids or Ringer's lactate, normal saline. And most patients even do not get adequate of those fluids. One of the two fluids may not be even available, and we didn't choose one of the two fluid types. We use whichever is available, and even we do not follow the clinical outcome, which fluid type has better outcome in our patients. We randomly use those fluids. So when I see different articles, even in patients who are septic, and different articles from different countries recommend balanced crystalloids than normal saline. So for patients in our case also, I want to choose one of the fluids better than the other, and I found this article interesting for me, though it needs study in our case as well, because even though it has ethnic it has no clear ethnic difference outcome in this article, it may be different in our case. So even though it needs further investigation, better to use the validated one, which is with better outcome, as well practice in the next case in our setup.
Great, thank you for that. We have a question in the chat. Thanks for posting it. Tasfei, sorry if I'm pronouncing it wrong. This is a question for Sarah. Is there any special recommendation regarding preoperative fasting for patients having associated associated diabetes as a comorbidity? So Sarah, is there anything that you came across in your reading or the paper or in your own practice you know of regarding any special recommendations for diabetic patients?
Okay. I didn't come across any papers for diabetes. I don't know, maybe others can contribute as well. But the diabetic patients, especially those with gastroparesis, can have prolonged gastric emptying.
So this is a question, and this is open to the floor. Fekadu, if you have answers as well to your setting, because this is an interesting question from Maruka Paul, who says, what can we do to optimize fasting in sickle cell patients? So I haven't come across very many sickle cell patients in my practice, I think it's fair to say. So perhaps, is this something that you see, Sarah, in Zambia or Fekadu in Ethiopia? Is this something you see that needs special attention, or something you see often that you need to think about?
Yes, we do have a lot of sickle cell in Zambia. I think they're usually done early on the list. I think maybe we could, if the case is going to be done later on, maybe we make sure we follow up the patient, make sure they're not starved for a long time. I think that's a great observation.
So that's interesting about starting early. So that's talking about organization of the case list, which in your paper, Sarah, seemed to be something that you were not doing in Botswana in terms of organization of the case list in the paper that at the time anyway when it was written. So that's interesting. That is there organization of the cases in your setting, and you take into account diabetics and sickle cell patients?
Yes, they do take into consideration, especially diabetic patients. But for sickle cell, yes, they would ensure that the case is done early. I think that's very important to emphasize. Sometimes it's overlooked.
And Fekadu, if you're with us, is that something you see in Ethiopia too often? You may have disappeared for a moment. That's okay, we'll come back to that. We have plenty on fasting anyway, so that's grand. So we have another question from Uspalu Lako, who mentioned the place of ultrasound in the assistance of judging adequate fasting time, which is an interesting question. That is something that I've just begun to see myself, sort of the discussions, not seen used, but the discussions about whether it has a place. Both actually, ultrasound's been used for the identification, cricoid pressure, and also ultrasound to judge for adequate fasting has occurred. I've not used it myself, but I've seen some discussions coming. Is that anything that you've noticed yourself, Sarah? Any discussions around use of ultrasound to judge fasting time?
No, I haven't come across it in my setting. We usually don't use it.
There's some literature recently out on that, so maybe I'll try and find it and post it in the chat for further reading. But it's not something I've seen myself yet, just some of it. I don't know about its use at the moment, but something we can look at further, and there's definitely some work out there on that. We'll just wait for Fekadu to come back for the next question on the fluid type, but we can move on. Oh, right, I see. So for Sarah again, I don't know if you've used this yourself. Oh, Fekadu is here. We'll just answer this very quickly. What's the current guideline of fasting using 4-2-1 in reference to children? Have you come across that practice, Sarah, at all, the 4-2-1 method in reference to fasting for children? Is that something you've seen before?
No, I've just come across the maintenance fluid in terms of the 4-2-1 while fasting.
Mm-hmm.
Yes.
And is there any specific guidelines that you're aware of in your practice for pediatrics? Because I saw in the paper that pediatrics was a particular problem.
So usually patients when they come in, pediatric patients, they're given usually a bolus of 10 to 20 meals per kg to cover the deficit. Then afterwards we start maintenance using the 4-2-1 formula.
Great, thank you. And I think it'd be interesting to hear some crossover on that actually, and then we'll ask the questions that we've got on IV fluid. Fekadu, is there any practice that you're aware of in terms of strict protocols for fasting for your pediatric population?
Yeah, in our case in Ethiopia, there is no strict protocol, but as she said, we use a protocol. Usually, commonly we use 4 hours for breast milk, 2 hours for clear fluids, and 6 hours for solid foods. Otherwise, there is no written protocol in our case as well.
Okay, that's interesting. Arusi, maybe put forward some of the IV fluid questions you've got.
Yes. I'll start with Flores Brad's question to Fekadu. So he asked whether there's if they're equally available saline and Ringer's lactate or plasmolite, I guess, and if you are aware of any price differences that may determine which one is being used more preferably.
Okay. Most of the time, one of the fluids, either saline or Ringer's, may not be available in the hospital, but most of the time, that are available, and I don't actually know the price difference in our case between the two.
Which ones do you see being reached for most commonly when you're in the hospital? Like, for example, if you're in the ICU or in theaters, which fluids do the clinicians around you or yourself use more often?
More often, normal saline is used.
Normal saline is used more often.
Yeah.
Okay.
Yeah.
And there's another question from Abraham about if there's any recommendations that you're aware of within your hospital about what the current recommendation is for fluid deficit replacement during an intraoperative period.
Actually, the fluid replacement depends on protocols, and usually it is based on goal-directed therapy recently. But in our case, what we do is we assess patients. We have different parameters for fluid assessment: the maintenance, the deficit, the third space loss. So we determine based on that, and fluid deficit is assessed based on clinical grounds of the patient. And there is no clearly documented fluid deficit replacement in the intraoperative period, but most of our practice previously was patient fasting from midnight was being put on maintenance fluid. But recent recommendations deny that the patient fasted after midnight, like usual people, have no need to be replaced as long as they fast based on the recommendation. It rather recommends to take clear fluids up to 2 hours before the surgery. Otherwise, there is no need to replace a deficit for patients fasting based on the recommendation.
Do you believe this is a field then that can be addressed in your hospital? Do you think, from reading the study and about the requirements for renal replacement therapy and things, that is something that may have to be changed in your hospital in terms of using saline versus balanced crystalloids?
Yeah, it may take a long time to have a common consensus in our hospital because the availability is one issue, and the other, awareness of the difference in outcome may also be another issue. So it may not be easy to easily address the situation.
Yeah, change will always take time. And just one last question. In the study, the choice of the fluids was left to the clinician starting the treatment. Do you think that affected the study methodology and the results at all?
Yeah, one of the limitations of this study was that may lead to selection bias. Otherwise, the it says the research was not affected by the choice because the research is on an intention to treat basis. So the clinician will order with indications. So it has not that much significance, but it may have selection bias in general. But in this study, it says it didn't affect the outcome.
Yeah, I'd like to take up a point. Fekadu, you mentioned we had the question about Rufi addressed regarding what fluid is readily available, and you mentioned saline. It'd be interesting to cross that over from Ethiopia to Zambia. Sarah, what common fluid would you have available that you would normally have if you reached for something?
It's also normal saline.
Okay, that's interesting. So that, I guess that raises the question: if this paper that we've heard today, does it have enough to convince you that you now need to change that? Fekadu, you presented the paper. We've heard both Zambia and Ethiopia that the fluid readily available is saline, and I guess cost needs to come into that. But does this paper have enough to convince you that perhaps there needs to be a change there? And that's Fekadu.
Oh, sorry.
I was just wondering, since we've heard from Sarah in Zambia and yourself that saline is the most readily used fluid, does this paper that suggests that a more balanced crystalloid should be used, is there enough in this paper to convince you that maybe there needs to be a change in that practice that seems to be common to these two different locations?
Yeah, so it shows that it needs a large randomizer trial to change this practice in Zambia as well as in Ethiopia, maybe in other countries as well. So based on this paper and other papers as well, in Hong Kong, there was a paper done comparing balanced crystalloids and saline as well in critically ill septic patients. And it also showed the same results, that balanced crystalloids are better than saline in those patients. So in Zambia and Ethiopia as well, it needs local randomized controlled trials to change this practice.
Yeah, that's a good point. I'd actually like to raise that, since you've brought it up, how this is obviously this paper you presented has taken place in 5 large ICUs in America, Tennessee, and it's about how applicable that research would be to the settings that we're speaking about here with yourself and Ethiopia and Sarah in Zambia. And an example would be that sort of the mean age is very different between the two papers. That's just one broad example. What do you think, both Sarah and Fekadu, about how applicable such research, such large papers are to your settings, and the need for more localized research in your own setting, unique to your own populations?
Yes, I agree. These papers are very important, and we need to get our own numbers and figures in our area and setting.
Yeah, what do you think on that point, Fekadu, as you presented that paper? Obviously, it provides discussion to think about. What do you think about the need for
COVID ራሱ ፓቶፊዚዮሎጂ is hypercoagulation, inflammation እና ያኛው ራሱን የቻለ ማለት isolated ለሆነ ኬስ ከሆነ okay.
Thank you. Just stay muted if you're not directly involved. Yes, Fekadu, is there anything you'd like to say further on that specific point?
Okay. As I said, to change this practice, it needs cooperative, large randomized controlled trials in Ethiopia as well. So there should be a cooperated research between different centers, or even a single center in Ethiopia. Maybe in a hospital I am working. If that is possible to do, it can be applied in the local area.
Thank you. And there's two further questions at the moment I think we'll ask. There's one specific one here that I'll ask as it's fairly specific. In Kumu has asked, so this for you, Sarah, in Zambia, do we use sodium citrate and ranitidine as a prophylaxis to prevent aspiration in case the patient is not adequately fasted?
Unfortunately, they are not readily available. Usually, you don't have them in stock.
Okay, and then, oh, sorry, go on.
Yes, especially sodium citrate. I think maybe we can start using ranitidine, which is available.
Thank you. And a more general question, I think we've actually touched on this already from Simichu, asking, is there any recommendation regarding preoperative fasting? I think this is, maybe this is specifically for malnourishment, perhaps malnourished patient, especially for children. That's an interesting one, actually, because we heard in your paper, Sarah, about the significance of prolonged pre-op fasting, particularly on the increased instance of hypotension intraoperatively in children. I think we spoke briefly about the need for protocols, particularly in the pediatric setting. Is there any special circumstances that you've heard of or spoken about in your settings? This can be for Fekadu in Ethiopia and Sarah in Zambia regarding children, but particularly malnourished children, any malnourished children that you might see?
Yeah, in Ethiopia as well, there is no specific guideline recommendation for malnourished children, but as it is already mentioned, children who are malnourished are especially vulnerable to intraop hypotension, as well as especially intraop hypoglycemia. So we take clear fluids 2 hours prior to surgery. Otherwise, I didn't have any clear recommendation for especially and specifically for malnourished children. There is no separate recommendation in Ethiopia, and there is no separate guideline. But we should be cautious that they are at high risk of hypoglycemia as well as hypotension intraoperatively.
Fantastic. And Sarah, is there anything you'd like to say on that?
I think that's a very good point. We also don't have any special recommendations for malnutrition, and I think we should be more aware now.
Great. And I also want to give a special thanks to Esubalu Laku. Many thanks, who's posted the article an article as an example of what I was speaking about earlier, about the effectiveness of ultrasound to assess gastric emptiness of fasting. So please have a look at that. And I think we're just about out of time, unless there's anything pressing that anyone wishes to say, please do now. Otherwise,
there was a question about diabetics and preoperative fasting as well. I know in the UK we do have some guidance which basically says to minimize the fasting period, and it will depend on what medications they're on as well. I don't know if any of the places locally have specific preoperative guidance. So Sarah and Fekadu might want to quickly say something on that as our very last question.
We usually don't have guidelines, but they try to make sure diabetic patients are done as early as possible on the list.
In Ethiopia as well, the recommendation for preoperative fasting is already as mentioned, but like patients at high risk of hypoglycemia and intra-op hypotension, and patients taking medications, especially, for example, diabetic medications and antihypertensive medications who are likely to be hypotensive and who are likely to be hypoglycemic intra-op, are better to be done and scheduled in the early morning of the schedule and early of the list of the scheduled patients. Otherwise, the recommendation is similar. There is no other separate guideline, but the recommendation as I said in Ethiopia.
Great, thanks very much. So I think we've heard, we're just about coming to the end. So thank you very much everyone who's joined us and listened in and heard our contributions today. Thank you very much to our two speakers, Fekadu coming from Ethiopia and bringing us that paper about the difference between balanced crystalloids and normal saline, and something to think about going forward, to look at that paper and think about the impact of that paper coming from big centers in America, how applicable that is perhaps to the settings that we've been discussing today. Also thinking about the power of that study and whether it has enough to convince you of changing your practice. We've heard the two places here in Ethiopia and Zambia that saline is more readily available. So does that paper make you think you want to change your decisions? So it's something to think about on that one. And then going to the fasting paper, thank you, Sarah, from Zambia, giving us an idea about the need for protocols in fasting. And we've had some special conversations regarding the circumstances in pediatrics where perhaps a greater need for protocols are needed there, specifically in conditions such as sickle cell or malnourishment. But we've seen that there aren't really any protocols that we've been able to identify. So that's something definitely to think about. And does it exist in your setting, and is it needed? This paper says yes. So I don't think there's anything else at the moment. I'd also just like to comment that it's been really valuable, I think, hearing the different voices from different areas. From us, Arifi and myself, based in the UK, as part of GASOC, Fekadu in Ethiopia, and Sarah in Zambia. It's been such a valuable experience to bring everyone together, and I really appreciate you coming at all these different scattered times that we've also had to do. And Sarah and Fekadu, I don't know if you have any final comments you'd like to make on just today's event, or any benefits you've had from hearing voices from different locations.
Thank you for the opportunity. I've also learned a lot.
Great.
Okay. Thank you for the GASOC team for the opportunity to discuss and to hear different views of the two issues raised from Zambia as well as from Ethiopia. And I hope this discussion will continue for the future. Thank you.
Dr. Sarah, you have box.
Oh, I think someone's giving you praise, which is always welcome, I think. I'm not really sure. But so yes, thank you everyone for joining. Thank you, Sarah. Thank you, Fekadu, for giving us excellent presentations. It was really interesting to hear the different perspectives. If you want to learn more about GASOC or learn more about ZADP or EADP, then please email GASOC and we can pass on further information about our group and the organizations that were here with us today. If you're having trouble, I've seen accessing the papers, also email us here at GASOC and we'll try and assist you in accessing those papers. You can look at them further and think a bit more of the issues that we've brought up today. If you have any further questions as well, discussion points, please email us at GASOC and we can pass them on to the relevant parties and we can try and get back to you with that as well, if you want to discuss anything further. So thank you very much for joining us, and I hope you have a good evening wherever you are.